a game changer. So the Fireside Chat Series is presented by Sai University School of Artificial Intelligence. And let's get started. Sir, over to you.
Thank you. Thank you. Thank you, Nilay, for setting the stage for today. So today's topic is artificial intelligence in preventive healthcare, a game changer. And I'm very happy to have three eminent doctors, I would say leaders in their own disciplines. Dr. Satyanarayana, Upadhyayula, Cardiac Care, Medanta Hospital, the Med City, Gurgaon. Dr. Vijayashankar, a specialist in neurology from Apollo Hospitals, Greens Road, Chennai. Dr. Rahul Singh, a medical doctor, plus head Center for Medical Innovation, Government Institute of Medical Sciences, Greater Noida. It is indeed a great pleasure for me to have all of you in this Fireside Chat Series. This is the fourth in the series. I would like to warmly welcome all of you to this chat series, and I would like to especially thank our attendees, being a Sunday, logging on and being with us. So without any further delay, let me take this opportunity to introduce our panelist. Dr. Vijayashankar is a specialist in neurology, having various fellowships with a super specialty in movement disorder. And he's a fellow of the European Board of Neurology. Currently, he's the clinical head of Apollo Movement Disorder and DBS program at Apollo Hospitals, Chennai. He has won several awards. He has been in several committees. Besides this, he has contributed immensely to the academic literature, about 31 articles in international journals and 3 book chapters. His specialty is Parkinson's disease, ataxia, and deep brain stimulation. Coming to Dr. Satyanarayana, is a well-known doctor specializing in emergency medicine. He has over 33 years of experience practicing medicine in various hospitals and clinics. He currently works at Medanta Hospital, Gurgaon, Haryana, as consultant cardiologist. Apart from association with various hospitals, Dr. Satyanarayana has put skills in the test of many other ways. He has been an active member of the Indian Academy of Echocardiography. He has completed fellowship in emergency medicine from Royal College, general physicians, and thereafter MBBS from Kakatiya Medical College. He did pioneering work in non-invasive and invasive and community cardiology, namely Satya's global mandatory sports licensure, Satya's multi-monitoring, Satya's electrocardiographic modality, Satya's ranking for GDMT compliance, Satya's fraction, Satya's HFPEF classification, Satya's protocol for HFPEF therapy, Satya's CPR, Satya's echotracheal tracheostomy, nostalgic tube, Satya's TE to minimize infection, Satya's clean technology optimized trial. So we can see he is a founder of several of these initiatives. His research interest is specifically in electro psychology, interventional cardiology, preventive cardiology, cardiovascular multimodality fusion imaging. And besides, he's an active contributor to the academic community in authoring several articles. Seeing all this, I guess he doesn't have time even to sleep. He is so hardworking. And today on a Sunday, he's attending a conference in Delhi, and at the same time, spending his valuable time with us. Dr. Rahul Singh is a very unique doctor with a degree in medicine and a MBA and plus a PhD. So you can imagine a doctor with managerial skills and with an academic flavor. He is currently a resident doctor at the Government Institute of Medical Sciences, Greater Noida, and it's India's first Section 8 public hospital-based medtech incubator. As in charge of Stanford Biodesign program at GIMS, he champions design thinking in healthcare and need-based innovation. An alumnus of FMS Delhi, Dr. Singh combines management expertise with frontline clinical experience. Specifically, has led the GIMS COVID-19 command and control center during those horrific days. And he has won prestigious honors and awards from the state government and various other national institutions. His research is specifically focused on several areas. During his PhD, he did his work on oral scope, a portable device for early oral cancer screening. So he spends a lot of time in advising health tech startups. That's how I came to know about him. So he was very popular in the, I would say, medical healthcare startup community, supporting clinical validation and hospital integrated innovation models like startup OPDs and emotion fellowship. So I think he's a very unique doctor in the community, having all these skills together, and he's a regular speaker at various forums. He's also a founder of Manavta, a national social impact initiative promoting preventive oncology, tribal health, and affordable care. So three eminent specialists with us today to discuss about the impact of AI in preventive healthcare. What I will do is, as we used to do earlier, I will, quickly summarize what is going on in this field. I would say summarizing from an academic perspective. Then, we will go into individual doctors with some questions. I guess without any further introduction, I guess all of us know how much AI is impacting our daily life, whether it is business, education, agri-tech, transportation, media, legal, you name it, you'll see AI is making terrific transformation. And healthcare is one such industry where AI is making a very big impact. Though a lot of work has been done during the last, I would say, 20 years, but recently, because of the invention of a few models and availability of cheaper computational resources, AI is now affordable and it is getting more practical to be used in a clinical practice. And the modern trend is shifting the focus from treatment to prevention and early intervention. So AI is playing a very critical role in preventive measures and predictive diagnostics, enabling more proactive, personalized, and effective care. So looking at AI, it can analyze, vast data sets, for example, like electronic health records, genetic data, lifestyle patterns, to predict the likelihood of a disease onset. So, for example, risk scoring models, just like we predict weather, looking at the sky, we are able to tell that, whether it is going to rain. Similarly, AI algorithms, could also uh, assess the probability of getting heart disease, diabetes, strokes based on patient history and biomarkers. Similarly, AI can interpret DNA data to predict genetic predispositions to conditions like cancer, Alzheimer's, or even rare diseases. Similarly, medical imaging, looking at X-rays, MRIs, CT scans, very often AI can, predict some incoming diseases, for example, detecting some early lung nodules or breast cancers, etc., etc. Preventive healthcare, from maintaining wellness, looking at wearable tech, IoT devices, looking at real-time data from fitness trackers, glucose monitors, ECG sensors, detecting abnormal patterns and sending alerts so that we can actually understand something bad is coming. getting more behavioral insights, tracking diets, exercise, sleep, and stress levels, offering personalized advice to reduce risk factors. Similarly, virtual health coaches with the invention of large language models, transformers, GPTs, nowadays chat bots have become more intelligent. The conversation, etc., could be more intelligent. AI-based apps can guide patients in medication adherence, mental health support, and even medications. AI can get into public health surveillance and even prevent massive pandemics. Uh, Epidemiological modeling, AI uses real-time data to detect emerging infections or even hotspots, helping public health officials plan interventions. Looking at social media, these days, a lot of things starts in the social media. AI can scan such platforms for health-related conversations, identifying possible public health risks early. Chronic disease management, for example, AI can predict a diabetic patient's risk of foot ulcers or even kidney failure well in advance, prompting preemptive measures. Similarly, AI can look at healthcare systems, segment populations based on risk, enabling targeted screening programs, resource allocation for vulnerable groups, etc. So basically, by preventing progression and avoiding unnecessary hospitalizations, AI also can contribute directly to a cost-effective healthcare. To summarize, AI in preventive healthcare can be used for predictive diagnostics, detecting diseases earlier, personalizing healthcare, reducing medical costs, improving health outcomes, empowering individuals to stay healthier and longer. So I think that is, like a summary of, I guess, I just summarized uh, a huge report, but I guess it can be much more. Due to lack of time, I guess I just summarized this in a very short format. So now we will go to the questions to our panelists. I will first address my question to Dr. Vijayashankar, neurologist. So, so Dr. Vijayashankar, MRI, PET scans, and biomarkers, etc., have been used for early detection of various types of neurological disorders. So, how much progress we have made in utilizing artificial intelligence in practice? And as a practicing doctor, what are some of the challenges you see in this field?
Thank you, sir. Thanks for inviting us. And this is a wonderful session, actually. The artificial intelligence has always transforming our neurological diseases. As you know, that the most of the neurological diseases we divide it into two, whether it is a curable, and almost most of the neurological disorders are progressive. If it is curable, it's easy to treat, but the progressive disease is very, very difficult for us to predict and treat how they transform and how we are going to help the patients. That's important. As you asked, like for example, and I hear that you are also more interested in Alzheimer's. Um, it's very difficult for actually many patients in the initial stages. They don't know what is Alzheimer's, whether they have a memory problem. Usually, sometimes they come to us and they say that, okay, I have some memory problems, short-term memory problems, and also they will search for money. They search for things where they keep the watches, phone, something like that. They will go for shop, and sometimes they will forget. Somebody, if the wife asks to buy five things, they'll go there and forget three things. Again, they'll call us. What is the other two things? These are all the things we notice day-to-day activities, day-to-day problems we see. But many times this can happen in common things like a stress or lack of attention because of the work pressure, all these things. But when most of my patients come to me, sir, I forgot what I'm going to do, something, I've missed appointments, all these things. So whether is it Alzheimer's? That's the first question they used to ask me. So how you do diagnose? Because when you look at the imaging, when you look at the MRI and PET, it takes at least 1 or 2 years to show the pattern of Alzheimer's. When you look at very early, we will not get these features. So that's the question mark we have. Clinically, the patient is symptomatic, but imaging will not give us a clue. Even when you do a memory assessment, that will not give us a clear-cut picture. So this is what we are looking at the artificial intelligence. If you look at the yearly signs, because if you do a MRI, the yearly MRI will not pick up anything like the temporal bone or the volume of the amygdala, all these things. It is difficult for us to pick up from the normal eyes. So these imaging, when you set a like a, if you take 100 people, normal Indians, or 1,000 normal Indian MRI, and have a database, and then comparing with our own, what is the patient's MRI, the yearly signs, the small changes, if it picks up, that will be really helpful for us. Or when you look at the imaging of the MRI, this artificial intelligence with the PET, we show the metabolism. Those metabolism will help us to find out where is the problem. Those things are really helpful for us. That really helps to diagnose actually in yearly diseases. Probably the many people now we are looking at the more like staging the disease. Is it more early or is it moderate or severe? That is also will really help us with the Alzheimer's really. And nowadays, people are looking into the CSF biomarkers. Like they do the CSF and then they look into whether the imaging CSF and the cognitive pattern will it helps or not. All these things are really helpful for us. Like in mostly this, in especially I'm a Parkinson's specialist. Like this artificial intelligence helps us, especially in walking. In Toronto, we had a gait lab. We always assess whenever the patient is walking, we always assess the gait stride, length, speed, and the width, everything we assess, and then we that helps because in a normal like a procedure, like we do a lumbar puncture before and after. So how will you assess? Clinically, we'll say yes, approximately this is better or not. But this gait mat and the gait assessment, the artificial intelligence gives us a clue before and after. There is lots of significant improvement. So it is not possible for us to assess clinically. And also the voice also we have looked into it. Like patients with Parkinson, especially tremors and all, they'll have a lots of voice tremors. Whether it is improving or not, we do a DBS and we assess whether this DBS helps improving in voice. All these things we tried. And also, as you told that there are lots of people are looking into biomarkers like alpha-synuclein and all. There are lots of things are going on now. And probably you can also help us to do a better work in India.
Thank you, doctor. I mean, you commented that progressive disorders, nothing much can be done, but watch the show, and it is kind of very difficult. And specifically, I guess you are dealing with, I would say, more progressive neurological diseases.
Yeah.
And coming to your specialty, movement disorders, what are some of the early signs of such disorders, and how do you think AI could do something to probably assist or like help the patient to understand that something is coming and probably be prepared and I would say have a better lifestyle during those remaining years?
Yeah. The important thing is especially two things will in movement disorder, like one, if it is going to be a tremors, many people think that this is a age-related factor. Like most of the Indians think that this is a stress induced. So most of them we don't care at all. That's the problem we have. One, the lack of awareness. Two, negligence. We just ignore it. When it becomes more, when the family members come to the patients and say, they say, yeah, you have some problem, please go and consult a doctor. Then also our patients don't come to us. So the important thing is finding these yearly signs, probably a app or something like that that can really help us. Like there are lots of tremor analysis apps are available nowadays. So these small apps always gives us approximately a rough idea whether it is a sometimes it gives us a whether it's a Parkinson tremor, essential tremor, and all most of the things it gives by the phone app itself. You get the information. And also similarly with the app itself, nowadays people are working like the voice itself, they are trying to identify whether they have a Parkinson's or because the speech will become soft and also sometimes it can become slurred in the like ataxia, cerebral ataxia. So most of the people are now working very early with the apps itself because most of the people doesn't want to come to the hospital, especially in our India. Money is the problem. So we need to diagnose these patients very early and at least they can reach the hospital early means we can see we cannot control all these progressive diseases like we cannot cure but at least we wanted to control and we need to provide the good quality of life and many people they can have a dystonia means the neck will be turned like this or sometimes the hand will be turned like this all these things with the app itself people are recognizing this dystonia and we can also identify these disorders early and if they come to us probably we can give the proper treatment and we can guide them properly. Similarly, as told that the Alzheimer's and we need to have more apps to diagnose, like a like algorithms, probably deep algorithms. Whenever even if the it is difficult for us, even in the initial stages, it is difficult for us to differentiate between Alzheimer's or is it Parkinson's disease, the dementia, or is it dementia of Lewy bodies. Clinically, it is very difficult for us to diagnose. Probably the AI can differentiate. Notice that people are working on it. These apps or deep algorithms can help us to differentiate the imaging, biofluid markers, MRI, and also the clinical input history, how it evolves from the clinician point of view, and the memory assessment. They can take into account, and then it gives us a clue. Probably these patients are turning more towards Alzheimer's or dementia of Lewy bodies. All these things are happening. Probably we need to look into that region. Um, how we are going to transform. Like in India, actually, doctors are working separately, and you people are doing a phenomenal job, like artificial intelligence. But we need to look into that aspect how we can work together and change our like information we discuss and do a research. How we can turn it into a better India, better Tamil Nadu. Probably we'll start from us.
Thank you for that wonderful answer and your remarks. I fully agree with you that we need to work as a team, and I think that gap is now, I think, slowly melting down. That is what I understand. Like 10 years before, I think both community doesn't recognize each other. Now I think we started slowly bridging that gap. And I guess over time, I guess we will all work together to do the best for the community at large. Uh, One question, being the largest, you're part of the largest private hospital network in India, and I'm sure that a lot of advanced technologies are currently being used. And what are some of the challenges you're facing or you're faced as a doctor in terms of using these technologies, convincing patients, or even convincing the management at large to adopt some technologies, or even representing your discipline as well. How much you trust these technologies.
Yeah, this is a wonderful question, sir. See, the important thing is in Indian setup, everything comes in the end of the day, how it cost. That's important for us. And also the access to the technology is very, very limited to us. So we have a lot of now we are working on, especially in elderly people, uh, there is lots of falls are having occurring. And especially in people with Parkinson's, there are lots of freezing of gait, difficulty in walking is happening. So we always now we are working on a couple of people with the work like a project with us the uh, like a wearable sensors, especially the gait shoes, and we are analyzing their gait, how it's like whether step length is worsening before the tablet or after the tablet, or how much it is over the time, how much it is worsening. That gives us an idea how much we have to address the medications, and we need to provide a personalized care because every patient is different. So we need to understand the patient, and so we are working on it. Second thing, every patient comes with different types of problems, and when they come to the hospital, immediately they want a cure. And especially nowadays with the Google, especially with Google and Chat GPT, they type headache 1 week, 10 days, and they come with the answer. Lots of patients comes to me with suddenly, sir, I have a 3 days headache, 4 days headache. I think it could be a cancer. So that's a common thing which we see in our day-to-day practice. And also suddenly they'll put into a, sir, I have I'm forgetting lots of things. I think I have Alzheimer's. So do something for me. So these are all the things Google and ChatGPT, they know, they give you a rough answer what it is. But the important thing is they don't know who you are and what is your problem. So lots of patients come to me, they will say that first, sir, please do a MRI to rule out a cancer in the brain. And then I will say, sir, okay, I will say this, what all your symptoms are doesn't look like a severe headache. This looks like a common cold and cough, like a stress-induced headache. This is a common thing we see because we know what is the patient from the history. We know we can understand the patient, and we can give you a simple answers for almost 90% of the patient. They don't have much of the problems, so we can easily sort them out. And then, but they don't know. Initially, people accept the doctors, but with advance of these tools, people are getting worried that I have lots of other problems. I have a patient, he wanted me to do MRI. So I told them, okay, let's, because I'm also worried whether he has some problem or not. So I have done a MRI and it was normal. I told them that you don't have any problem. After 2 days, he came back, sir, I still think the MRI cannot rule out a cancer. So I want to do a PET scan. So I told him, I told him, I'm not going to advise you. Somehow he met somebody else and pressured, and he came back with a PET CT scan, and then the PET CT scan was normal. And then he told me, sir, he went back. I told him, sir, PET CT is normal. Don't do anything. That's nothing more. He went back and read all the Google and came back. So I want to do a lumbar puncture. I do a CSF analysis, and you prove that there is no cancer for me. The other thing is the artificial intelligence doesn't know who you are, and the personalized care, the patient wants a cure immediately. But important thing is stratifying what they have is very, very important. So all these things challenges we have, but only thing is the advantage of the this artificial intelligence is sometimes we know that there are lots of new things are happening. It is difficult for us to uh, update everything in the field because nowadays even like I'm more into neurology and movement disorders. Sometimes I don't know what is happening in diabetes and what is happening in the cardiac problems. But probably people in Chennai, they know that they'll accept. I'll say, sir, I'm not a cardiologist. I'm not a diabetologist. So you please consult a specialist on these things and get the opinion. But immediately they will say that, sir, give some your idea what it is. So these things will artificial intelligence helps us to give us some rough idea what is happening, so we can help the patient. And also the problem is how we are going to predict the patients who are from the villages or remote places. That's a challenge we have. We are working on it. Like as you have mentioned, this how to prevent a stroke, like this artificial intelligence we need to integrate, like how we are going to prevent the stroke or heart attacks. I think we need to implement all those things in the primary care, especially in the remote places, and we can provide the like a our expertise to help the people in remote villages and other places, sir.
Thank you. Thank you, doctor. Thank you so much for your inputs. So I think we are actually running short of time. So
Thank you.
yes, thank you so much, doctor, for your input. So we'll move to the next panelist, Dr. Satya. So my first question is from your clinical experience in cardiology. Could you please highlight how much AI has been used for early diagnosis and risk stratification?
At the very outset, I would like to thank Professor Ajith Abraham, Vice Chancellor of SAI, for inviting me to this exciting meeting, Fireside Chat.
Thank you.
The
Thank you.
moment I saw your WhatsApp, I recognized this is a very good niche unmet area for discussing on webinar. This is a very good initiative from your side. And I also requested you, if I remember correctly, to conduct it every month,
Yes,
not
yes.
just once in a blue moon. Every month I told you, conduct it. And I also advise you that all your students of SAI, there must be at least 10,000, I think. All of them should attend this. Make it mandatory. Give them credits for attending it. Make it half an hour. Doesn't matter. Make it
Yes.
half an hour. So that now they don't have any reason कि मेरे पास time नहीं है. I'm busy with something. Okay, I'm taking 1 hour out of my conference and I'm attending it. They can attend for half an hour. They will get credit. Okay. Why I'm saying this? Because younger minds can be more productive, more innovative than us. It is always possible. And perhaps they will be doing more things which we wanted to, which we have in thoughts, ki we should do this, that, but they may be able to do it because they are very young. And you see, most of our innovative big companies, they have started in garages, small garages. So we want garage startups, especially in AI, in healthcare. And let me tell you, all the departments, the partitions we have made, cardiology, neurology, nephrology, urology, these are all man-made. We have made them. So let there not be anything to restrict the mind to going from one field to another, mechanical. There are numerous fields in engineering, numerous fields in medicine. Don't put any partitions because they're all connected at somewhere or other. Even metallurgy. Look at all the stands we put. It is all because of metallurgy. Okay, so we can't say कि we are not connected. We are all connected. We're all. It's only when we connect the dots we can solve the most difficult problems of modern day. And AI in healthcare, in cardiology especially, the fundamental is this: AI is useful in every field of cardiology. Every field. If the ocean is made of drops of water, okay, it's like it is a content of every drop of water. If our entire field of cardiology is, let us say, is information, we have knowledge, we have intelligence. In all of them, AI has a role. So presently, we are not able to use AI to its maximum capacity because our basics have not changed. Let me give you an analogy from imaging. We have what is known as 3D imaging in cardiology. In 3D imaging, we take the image from 2D and reconstruct the 3D. So people are swayed by 3D imaging, 4D imaging, but they don't know it is the 2D which gives the quality of the 3D and 4D. So if our 2D image is not good, 3D and 4D will not be, they will be worse. So in the same way, to make best use of AI in cardiology or in any other field, our basic data has to be very good, excellent, no redundancy. It should be systematic so that the transformers, the chat GPTs, they can take over. Another thing is there's need to be a lot of collaboration across countries. There should not be any borders across countries, across specialties. Then the effectiveness of AI will come up to its optimum. In cardiology, we are using AI in every field. You name it, we are using it. But it is not honest in a way like there is no proper collaboration. Every institute has its own, especially in abroad because of where we have these IPR issues. People don't want to share it. There is secrecy. There is a lot of money there. So, and especially the private biggest companies like Google and Microsoft, they are all into it, and they all have monetary monetary intentions because they are spending a lot of money. If they're spending money, they need they need money back. So that way, things are going on. But as I see in cardiology, in every field, we are using it in primordial prevention, primary prevention, secondary prevention, tertiary, and quaternary. So in every area we are using AI, but still there are lots of things which can be done. We are still in the infancy. We are taking baby steps towards optimal use of it. And I feel everybody should be involved. The patient, the doctor, the technologist, everybody, the industry, everybody should be involved. And I feel there's a lot of scope. And Dr. Geoffrey Hinton, the father, godfather of AI, has very clearly mentioned he is not happy with AI the way it is being practiced across the world. He feels there are three types of people in the entire this thing. One is the good, the bad, the ugly. The good people are we. We are always thinking of how to give benefit to humanity, how to use optimal AI, how to reduce costs, how to prevent disease, and how to promote health and wellness. But then there are the bad. There are companies, people who want to go beyond the scope of it, wherein it can become autonomous. It can, we don't know it's what will happen once it becomes totally autonomous, and we don't know whether it will take over humanity and finish humanity. Then there are the worse, good, the bad, the ugly. The ugly are those who want to use it for, terror purposes. So these three are there, and Geoffrey Hinton has very clearly told there has to be regulation, framework, guidelines from the governments, United Nations, and the big companies like that of Tesla and Microsoft, Google, and so on. So we need regulatory frameworks. We need collaboration, and across the fields of cardiology, not just cardiology, there are 100 specialty in medicine. The same framework will work everywhere in neurology, cardiology, similar problems, and it can work wonders. It can bring down the cost like anything. It can like our villages. You see, there are 6.78 lakh villages in India. How will reach? How will we reach them? We don't have. There is no way other than through AI, through robotics, through humanoids, through androids, through cyborgs. We have to reach those villages, and it is possible. On white paper, I have already mentioned everything. I have submitted to the government of India, and I think I want to. Bring out one thing that Dr. Professor Ajith Abraham is also part of the MOOCs trial, the Indian Registry of Cardiology, and we are working in this direction. And I am very much happy with Dr. Vijayashankar's comments on how we can prevent various diseases, how to reduce costs. All those things we have put it in our written form in our this Indian Registry of Familial Hypercholesterolemia. We are making this registry, and we hope we'll come up with something which will be useful not just for cardiology, across all the fields in medicine and wellness and prevention. So, with these few words, I would like to interact with Professor Ajit Abraham and his colleagues on the Zoom, if they have anything to discuss or ask me. Yeah,
Thank you, Dr. Satya, for
yeah,
those
yeah,
nice victory
yeah,
marks. And
yeah,
definitely, I think all of us should work as a team to.
yeah,
And I guess because I don't know whether it is because of lifestyle, I think
yeah,
basically the numbers are also, getting on the high
yes,
number of patients are getting on the
yeah,
high side.
yeah,
And my next question is towards precision treatment. We have seen like, or we have, seen cases where, like robotics and assisted technology is being used, for example, for a catheter ablation or even valve replacement.
yeah,
How much, we have achieved in this direction, and such
yeah,
technologies
yeah,
can be relied on, specifically, when you want to, like address masses, because like I mentioned, the patients are increasing and probably we need more technology because there is also a lack of number of
yes,
doctors.
yes. That's an excellent question. It is a very challenging area, very challenging. One is you have to, talked about RF ablation. Atrial fibrillation is very common in our patients, and RF ablation, robotically controlled with AI, is the future. It is the future because humans, we have limitations. We can do one case, two case. After that, we're tired, and tiredness brings down our efficiency. And again, next day we have to reach the clinic in time, on time, which is again difficult. Okay. So when we start a case, we don't know what is the end time of it. Start time is there, but we don't know, it may take longer time because of complications and so on. So this is the problem in all areas of medicine, not just cardiology, in neurology, in every area it is there. So here comes AI and robotics. Robotics can beat us by miles. They can beat us by miles. One thing in endurance. If we can do one or two cases, they can do 100 cases. No tiredness, no laziness, no problem. They don't charge you extra also. Yeah. So that cuts down the cost and efficiency, and they don't have this tremor problem. If we stand for very long and doing things, our efficiency goes down. So this robotics and AI can increase the efficiency by bounds, length and bounds. And I feel, especially in RF ablation, we operators are exposed to a lot of radiation. So we cannot go on taking the radiation for very long. So we need AI and robotics in the lab. It becomes essential because now we can operate from a distance so that the radiation exposure is less. So there are several stages of robotics. As Benjamin has stated in recent 2025 article in MDPI, he says that robots can take over, but in stages. The present stage is like in TAVR and in RF ablation, the entire process is controlled by the human. The robot is a tool in the human's hand. So what Benjamin et al. Say is the next stage is you divide the process by steps one, two, three, four, and at each step, give the robot and make it autonomous for just that step with your under your this thing guidance. And the next step is give it more steps. Out of six, give two steps, three steps. And the ultimate is that might take a decade or so when the robot can totally do it autonomously without human guidance. That is the thing. It is like the metro train which runs, and the driver is just for he's just sitting there. He's doing nothing. He's not required just for legal reasons. He's sitting there. Otherwise, our metros are driverless. So it is like a doctorless cath lab wherein the robot is doing everything without taking any instructions from the doctor. Because from time to time, the robot may change its decision according to the requirements within the lab, and the robot can hold more knowledge than the doctor across because they share all the cath labs will be connected. So they are in real time connected with the guidelines as well as hard data. So I think that is the future. It may take few more years, many more years, maybe a decade, but that is the future, and it will bring down. It will bring in a lot of efficiency, bring down the cost by good magnitude. This affordability of advanced procedures will become very good. Even a common man will be able to afford these procedures for a very, very, very expensive. This TAVR, RF ablation, they are very expensive. So all this cost will come down. So even the common man will be able to afford it under the Prime Minister's Yojana, this Chanda Yojana. That's PMJ, what they call it. Under that Yojana, every Indian will be able to afford it. Yeah, yes. And TAVR is a very, very, very advanced, very challenging procedure, and it has saved hundreds and hundreds of lives in whom we cannot use surgery. They cannot undergo surgery because they are already having numerous other comorbidities in the form of renal disease, hepatic disease, lung disease, neural disease, and age and obesity. These are very common nowadays. So when these comorbidities are there, including smoking, surgical risk will become it becomes too high, so it becomes prohibitive. You cannot touch the patient with the scalpel. So there we put in the catheter and put in a valve there, and this is all high technology. This high technology, we have to take it to the next level of AI and robotics, wherein it will help the humans because AI robotics can definitely increase the skill the overall performance, efficiency, accuracy, and long-term outcomes of this TAVR and RF ablation. There are many other procedures similar to it. Like TAVR is, we're changing the aortic valve. In TMVR, we're changing the mitral valve. In TPR, we're changing the pulmonic valve. In tricuspid valve changing, we call TTVR. So all four valves can be changed percutaneously from the lower limb by putting a thin catheter. From there, it happens. So the valves can be changed, and we take information from MRCT, everything. All the information is put together. All the imaging information is fused together, and then we get an idea where to put the valve, what size is required, and so on. And the results are excellent. The 5-year survivability is very good, and the on-the-table death rate is very, very low. So this is the biggest, we can say, the change which has happened recently, and it has started with Alain Cribier. Alain Cribier is Professor Alain Cribier. He's in France. He's the chief of interventional cardiology in France. He has done the first in human study of implantation of the aortic valve percutaneously. Till then, there was no other way than to open the chest surgically and put the aortic valve. And once you subject the patient to surgery, the mortality will go into the sky. It will go through the roof, very high, very unacceptable, very prohibitive. Costs are also high. Now, after Professor Alain Cribrier has started his first TAVR, now it is practiced all over the world, all over the world. And not only in high risk patients, but in mid risk, and even now it is coming to low risk. People with no risk factor also, they can be taken for TAVR, because our experience has brought out newer technologies, made it more safe even for normal persons. And the thing is, surgery may become going to history books very soon. And once AI and robotics will also come in, I think nobody wants surgery. Now, even surgery, I think, should be done only through the catheters now in future. That's what people see. We have laparoscopic procedures. It is something like that. In laparoscopic cholecystectomy, etc., we put a thin tube through the abdominal wall and do the abdominal operations. The future would be to put thin catheters, which are pliable and very flexible. These catheters go through the arteries or veins, and surgery is performed robotically with the help of AI, with the help of micro electromechanical systems, because everything is micro level there. These things can be performed through catheters, and all patients will say, I want to go for this type of surgery. I don't want to go for that old type of cutting big incisions and doing surgery. Everybody would like to go for AI assisted robotic intra trans, you can call it as percutaneous trans catheter procedures, because there the blood loss is minimal and the hospital stay is minimal. Results can be excellent, and mortality, etc., will be lowest, and 5-year outcomes will be the maximum, and costs will come down to the earth, to the common man. That is my prediction for the next 10 years.
Thank you. Thank you so
Yeah.
much, Dr.
Yeah.
Very
Yeah.
educational, and I think certain
Yeah.
things, even for me, it was surprising. So let us all hope for the best. The
Yes.
yes, we'll be able to do a lot of things for the
Yeah.
city at large. And we are running short of time, like you
Yeah.
mentioned, to do this possibly, like every month or every once
Yes.
2 months.
Yes. Every month we should have it. Every month. And all your students should mandatorily come into it. All your students. Make it a point. If they attend, they'll get a positive credit. If they don't attend, they'll get a negative credit.
Yes, yes. Thank you so much.
Yeah.
So
Yeah.
we will move to the next panelist because we are running short of
Yes.
time.
Yes. Yes.
So thank you
Yes.
so much again once more. So,
Yeah.
so my next question is for Dr. Rahul. So we have seen recently in the last, I would say, last 5 years, the government of India, the startup India, then the AI mission, and basically we are seeing a lot of healthcare related startups now focusing on various aspects from diagnostics to telemedicine, mental health, elderly care, remote monitoring, etc., etc. And even the venture capital in healthcare startups has exceeded about 20 billion, like a pan all over the world, especially during the last few years. And what is your viewpoint, since you directly work in the startup ecosystem? As a country, India, how well we are placed in this race, and what do you think, from your understanding, how we can do this better, or we are doing at pace with other countries? Do we need something better? What are your insights?
A very good morning, sir. Thank you, Ajith sir, for having us here. And what a great day it is. Today is National Technology Day as well.
Wonderful. Yes, yes.
And what a coincidence that we are having the best of the people from the country, I being the youngest. Uh, this is interesting where clinicians talk about their viewpoint, and it is very important to understand what AI means to us. Coming from a clinical background, when I practice dentistry, and when I sit on the policies of government, the most important thing that our clinician need a message from the technology community that this device or this technology is safe. Safety is something which should come as assurance. So I'll tell you, AI. Everybody in the world knows that the AI is creating breakthrough, and probably in the healthcare is a larger space where the preventive part of disease can actually be managed with lot of AI tools. But then to apply these AI tools, there are too many regulations. As a country, not just India, globally, when we see the use of data, and then in the healthcare, there's a lot of data secrecy. There are a lot of ethical issues which are not yet even talked about. As an incubation center in a public hospital, we receive too many startups working on AI where they just want the hospital data. As a healthcare professional or anybody working in the healthcare system, it is a very much mandate that whatever data that we generate in the clinical setting, or whatever the data or whatever the communication that we had with our patient, that's top secret in between me and my patient, right? The data that we generate in the clinical setting, how that data would be used for machine learning. See, we cannot stop AI from penetrating into health. And it is similarly like when in 1990s, when people said that computers will not be required. And in 2025, all of us are using it. So doctors will have to learn the use case of AI and then decide what is the right area until what. It should be assistive. Till the time it is assistive, it is helping in better decision making, this becomes the part of the system. But just to give a few examples, even we are a Stanford Biodesign Center, and there are few startups coming down, for example, and then we need to convince our clinicians that this particular mechanism is actually solving what we solve as a clinician. For example, there was a startup that came down to our center that with the voice, you speak to the app for 20 seconds and we diagnose your mental health condition using AI. Now, when this startup pitches in front of my clinicians, they have been professors for last 10, 20 years. We have to tell them, just the 35-year boy coming down that I will diagnose everything, all mental health conditions. One needs to understand mental health condition is the umbrella. Anxiety is a different symptom. Depression is that's a different thought process. And then we have to categorize things. There's something called disease process. And then people even do not know. See, there's a lot of what sir said. I totally agreed with him that good, bad, and ugly. We have to understand that when anybody is coming down to the hospital with a tool that this is what we have made for the doctors or for the healthcare, they need to understand that do they understand the business of disease? When this startup came down to our center, my clinician said that we have been practicing medicine for last 20 years. In the psychology OPD or in the psychiatric OPD, we have been seeing patient. How does the patient walk in my OPD? I virtually see that. How does the patient respond to my verbal communication? I read that. Then I write few tests to come down to a differential diagnosis. And after those differential diagnoses, I come to a final diagnosis. There are processes where I claim that this patient has this, and you can only listen to voices and tell that this patient has this particular diagnosis. So we need to develop mediums which are assisted, number one. Decision taking system, not, but it should be decision assistive system. A tool that helps doctors in making better decisions, then only the absorption would be really better. We need to talk about how can large data centers, because the AI is all about data and machine learning, large data centers like public hospital, how do we integrate it? Is the Ayushman data available for integration? The answer is no. Why? Because till the time we do not have very firm regulations. Then one more very important thing, nobody is listening to the clinician part. Probably, I guess I should thank Abraham sir for getting clinicians to talk about AI. Nowhere in the country you doctors talking about AI, because we're not given platforms. Everybody who's playing with AI considers healthcare as a business only, or as a buyer business. We have to co-create together. For example, there's a clear difference between a psychologist and a psychiatrist. Today in India, if there are 10 startups, if you throw a ball on them, 4 of them are into mental health condition. And sir, when I see startups both in the public hospital and at different platforms of government, people who are not from health, they do not have this clear understanding the difference between a psychiatrist and a psychologist. Clinical psychologists in the market are deciding the intervention. Technically, it is not allowed. That is where this doctors community is. Well, people normally say doctors are not very open. They are not very not understanding. It is very important that, see, there are orthopedic doctors, there are therapists, right? Therapy comes as a complement to the surgery, right? We have to understand this. Psychologists and psychiatrists. Psychiatrists can actually do the medicinal intervention. But then, because there has to be a business model, you cannot afford a psychiatrist. You have onboarded 5-10 psychologists, and then they are deciding you have got neurological conditions, aapko ye karna chahiye, you should do this. That's ethically wrong, and that is where probably we need stronger regulations. That is one area. Of course, AI is growing up really well. Even at our hospital, we are getting we have a very prominent startup using the data from CT and MRI. And see, we have to understand that in the entire healthcare science, radiologists are not available everywhere. Teleradiology is a boom, and it is a blessing. We need to understand that which are the places where AI can actually be absorbed in the system and can actually enhance the total outcome of the patient care, or in total as a hospital setting. Telepathology is going really well. Telepathology, as in you have to read slides. So, and then of course, too many genome sequencing, and these are the larger areas. But as an institution and as somebody, you are one of the best who understands AI. We need to know that the AI will come up with preventive plans, personalized plans, community-based screening. But then we need to decide how this data will be, because wrong data will create wrong model, and wrong model will give wrong results. And that is where startups fail in our country, because AI is totally new to the world, right? We see most of the countries which have having good data, they create good model, and their precision of diagnosis is very, very close to the reality. So that is one area. We need to have a common platform where we actually know that what is the ethical way of giving data, how should the model be trained, and integration and co-creation is the key, where in the hospital setting, we create that data bank together, and then we make the model so that, and that model cannot be universal. African data does not directly correlate with the Indian data. So we need to have people who understand the data business better. We need to have the clinical people together. And then this is going up. The moral responsibility is that the patient care should not be compromised at the cost of using technology. So technology should be a complementary thing. Technology should make it affordable, accessible, but not at the cost of quality. And when we say quality, so in healthcare, you cannot have two qualities. Healthcare by default means it has to come with quality. There cannot be quality A, B, and C. So that is where we see medical devices converting into an AI integrated medical device now. Most of the medical devices made in other part of the world using AI model are doing better because they have been in the market, they understand the business. This clinical integration is really good. Into our Indian system, where we are just trying to get better, I guess, more better hand-holding, including clinicians in the very early stage while designing it. See, we clinicians do not know what is machine learning. But then we know that what the machine is going to learn from the data that we have generated in my OPD, that we know. We do not know how to make the car, but we do know that this oil which I'm generating in my OPD is through that you will make the models. Why not to discuss with us? For example, in oral cancer screening, the device which I have made, see, it is like a lot of screening. For example, tuberculosis. In tuberculosis, early screening through the prediction of just X-rays could be magical. We need to see that how we can actually empower our community workers using AI-based devices so that the footfall in the hospital goes down. At least preventive part of the disease is caught early. And if the preventive part of disease is caught early, the amount of money spent on the health will also go down. So we need to see it at a total. And talking about the overall future of AI will be like a mobile phone soon. Nobody can stop it. Doctors who will resist AI, I guess the clinician will get finished. Only those clinicians will exist who will coexist with AI. So that's the future that we see from the clinical perspective. And then clinicians are very, very open to interact, correlate. That is how when the last panelist was talking about, we need to have common platforms. So we have started something called a startup clinic. So startup clinic is where people come down to the hospital and discuss with our clinician that what sort of thing they are making. So more of these platforms, and then platform which Dr. Abraham has created. And that is what is the need of the hour. That is what we understand. AI has to be of the same passion, how passionate a clinician is. And it should assist the clinician. That's my take, the final take.
Thank you, Dr. Rahul. Was really nice. You're given a complete overview about the whole kind of issues connecting, both worlds. So you mentioned about, like especially in India, I guess, you mentioned about 4 in every 10 startups, 40% of the startups are related to mental health care, 40%, and which is kind of alarming. And how about 60%? Can you tell, which all areas, at least?
Okay, so like if you see, because we are a very specific healthcare startup incubator, but if you see in general, most of the startups are coming into SaaS model. They are all into service. So if we divide the 10 in number, so probably very few of them are into hardware as a medical device. See, this healthcare industry, if you ask any clinician, 90% of devices we are importing from other part of the world. We're not creating in India. The reason being, probably the creators do not know what the doctors need. Probably I am using a device where my capacity to do a particular third molar extraction is pretty much very best with that particular instrument. But that instrument is not made in India. And every doctor, they have a set of comfort zone with their instruments because that decides the patient's outcome. We need to talk more with the clinician. What is the devices that you use inside the OT, in your OPDs? Are they made in India? If not, can we make in India? So that is what make in India is for us. Can you make Indian devices which can be used by doctors? What is happening is most of the startups, they are just making out of they saw a thing at Shark Tank, very next day that becomes the problem statement. The problem statement needs to be validated with a hospital. Is it really required? And if it is required, how will that scale up? If you see, when the largest problem was there, the world never saw an antigen kit. Only RT-PCR test was there. The best of the innovation came was an antigen kit. And that is scaled up. See, if at all you're making, after knowing that there's a need, that business will scale up. Slowly, we are going up really well. There are a lot of policies from DST, from BIRAC, supporting medical devices, but then we need innovators who need to talk to the doctors in the hospital and then try to co-create something. Thermometers have become digital, right? 20 years back, it was not. The normal BP machines have become portable and handy. The healthcare will be easy to use for everyone, but then why we bite from other part? Because they are doing it better than us. So we need more of platforms where people need to understand the problem statement, make more devices in country, because if you have to, it is easy to scale with devices, but everybody is making a SaaS model, and then if everybody working in mental health, probably 40 of them, 60 of them is creating something which is a copy of something which exists everywhere. There's a misunderstanding of entrepreneurship and innovation. In healthcare, we actually need to innovate in India for India, because in India and for India, innovation has to be affordable and with quality. So that is where I guess government institution like us, we need more institution like this, where we actually said that, our clinicians are ready, come down to us. Once in a month, we call everyone. But then there are very few attendees. People do not know that a cardiology requires, he uses so many instruments. Cath labs, machines in cath lab, not made in India. MRI CT machines, not made in India. Ultrasound machines, if made, they're not very, very close to what we use in the OPDs. So a lot of problem statements are there. If at all we design it together with a purpose to make it affordable, the government wants to buy it from both sides, but then government has to buy with a particular standard. Although the regulations are tough, and why most of the standards, they do not come down to the medical devices, sir, because the regulations are tough. It takes like little longer time. And in the preventive part of the disease, there are very few investors, very few investors. If you ask them that you're working on diagnosis of TB and you are selling a device which is for 10 rupees, everybody, VC wants to multiply their money. That's one part which has to be understood very clearly. That is where government are investing funds on grants so that you make the prototype. But I guess working on the right problem statement is very, very important. And then that is where we need clinical immersion program before you think of a startup. Go to the hospital, be there in the hospital for a month or probably for a week. And the hospital also needs to start a program like this. Like we have a program called Stanford Biodesign. Stanford was doing it in their country. India also started a similar program called International School of Biodesign, where engineers, they come, they stay in the hospital, they know the problem statement, go back to the engineering school, and then they make a device, again come back for validation. We need collaborations to understand what the clinicians need and then make it for them. Not just make something and put it on them that, which goes through a MR, and then the community blames, Dr. Sahab, he charges money for this and X, Y, Z. So we need to come together and make this Make in India concept really impactful, not just design in India. Most of the IPs that you see, sir, you will see that it is all design IP. Very few of them are of functional IPs. Very few of them are process IPs. You are wearing a specs like this, I put up a third line and make a very different design, and you flaunt that I have IP. So we need to appreciate that, everything converging together should improve patient care. And in the healthcare setting, doctors are the prime face, and doctors are evaluated on the patient output. Doctors will never ever compromise on that. So we need to have tool and technologies. And talking on this technology day, it is very, very important. We need tools and technologies that complement the doctor. Not with a promise that we will finish you. हमारी तो doctors की जरूरत ही नहीं है. ऐसा कभी नहीं होगा. Everybody who is skilled, the magic in the hand cannot be replaced with the machine, but machines can make it a little better. हमारी fatigueness को कम कर सकता है. So that's how we see in total that AI is a very blessing wala tool. It is a very good tool, but it should complement with better decision making, so that we can actually reduce the OPD timings. We can actually focus on the patients who actually need the clinical intervention. And public hospitals which are just flooded with too much of patients, if screening can be done, Anganwadi Asas can be more skilled with AI. I believe AI will do magic if the last line of the workforce, Anganwadi and Asas, are well trained with it, so that the hospital only gets patients which needs cure. So that's how I see in total AI as a tool for community.
Thank you, Dr. Rahul. It was really wonderful. I'm very happy that all the three panelists have a very similar opinion, how to bridge gap towards developing various technologies so that we can do the best for the community in providing the best healthcare, especially preventing some incoming things. So I'm sure that in the future we will have a lot more platforms, a lot more initiatives. I guess these type of things should scale up. We need more platforms so that both communities can share our concerns than working in silos. I guess in India, like Dr. Rahul mentioned about the issue with quality aspects, sometimes people are blindly going with numbers. They just need numbers to get certain targets. They don't look at the utility or something that could serve the community in the long run. So I think we also need some educational aspects. This probably might need some time, and probably like we need efforts beyond the things the way we are doing. I think probably it's a matter of culture as well. We should do certain things at I think basic university level to educate our new generation, focusing on quality, focusing on understanding the community in a very big way. Because what I see is the 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 new generation innovators, they want quick results, and and they don't have patience, and they want get back investment or whatever it is in less period of time. So there are a lot of challenges, and besides that, like you mentioned, getting approvals from various regulatory mechanisms also offers a bottleneck. But I think these things, let us hope that will change for the good. And I would like to thank you for your spearheading efforts. I see that you're doing a lot of things pan India, and I think it is really admirable. And please continue doing your sincere efforts in this direction. I also would like to thank Dr. Satya for spending the valuable time in spite of a conference is going on. He has sneaked out to spend time with us. So, and also special thanks to Dr. Vijayashankar. Actually, he has some intervention in his hospital today. So he just went, he also went to attend that. So my special thanks to all of you. And since we have uh, exceeded the time, I'm sorry that we'll not be able to take any direct questions from the audience at this stage, but definitely, like Dr. Satya mentioned, we will come back probably in the next few weeks, and we will continue these discussions probably in a much wider scale. And once again, thanks to all the panelists on behalf of the university. I would like to thank all of you, and all attendees. I thank once again, and wishing you a happy Sunday and nice day ahead. Thank you so much.
Thank you, sir. Thank you.
Thank you.